For those kind words, I need to start by deconstructing many of the things Prof. Zanaya has said. I am a gate crasher, and I will always remain a gate crasher as far as settings such as these are concerned, because I am like fish out of water. I am out of my elements when I come to a forum such as this. However, I'll be sharing with you some strategy by which I pretend to be part of this kind of community. So in this presentation, I'll be looking at the whole concept of the power of the patient. Again, words are ideologically loaded. I decide to speak of patient, not of consumer, because the take on these words is very different and carries a lot of ideological baggage that we'll be seeing in the course of the presentation. So when somebody says the health consumer and all of that, it's not a neutral term. It comes with it a set of attitudes, a set of processes, and I'll be suggesting that we need to be mindful of this. So I'm going to be suggesting that yes, there are two discourses currently in the area of health as it relates to the power of the, let's take a more neutral term, care recipient. There are two kinds of ways in which people talk about us when we are ill or when we go to see a caregiver. Although we talk about power commonly, we are going to see now that there are two conceptions of power, and that one conception of power is actually subverting the other conception of power. Okay? There's a group of people who use the term power. There's another group of people who use the same term power. But power for these two groups means something completely different. And I'll be trying to illustrate to you that one group, a more powerful group, is undermining, it's subverting the power which the other group talks about. Okay, so let's start with that discourse that focuses on the patient. Now, some people don't like the term patient because they think it means passive. But originally, the term patient meant somebody suffering, okay, somebody who was ill and needed help. Now, you begin to get a sense of where I'm coming from when I say I'm a crasher. All I've simply done has been to pick many of the words that have been used in the course of this summer school. And, you know, in one or the other papers available on the subject. The patient-centered discourse, as far as power is concerned, would be associated with many of these terms, and this is actually my entry point into this subject matter. I've not read all of the fact books written by Prof. Zanaya and his colleagues at the center. I don't know what the issues are, but one thing I know is that a text means what it means because of words that have certain meaning. So it does not matter if Prof. Zanaya writes a 500-page word, a 500-page book. By looking at some of the words he uses, I can get a sense of what the book is about. So essentially what I've done has been to look at some of the words that are used within the context of what we call the patient or the citizen-centered paradigm. Okay, so we might take it further by trying to group these words to make sense of what this discourse group is talking about. Okay? Words that are highlighted in red speak towards solidarity, to community, to pooling of resources in order to serve the needs of the community. It's not an individual sort of oriented approach. So when you talk of health insurance, what are you doing? It's about social solidarity. When you talk of using tax to fund health, again, we are pulling together solidarity. When you say strong state responsibility, what are you saying? You're saying that the state is responsible for the health of its citizens as enshrined in the constitutions of many of our countries, even though, as we'll see, and as Professor Kadar eloquently pointed out, with time, with the neoliberal advent in this sector, we are redefining even concepts such as, I think you give an example of universal health care. So that is being hijacked and being redefined. So here we are talking about welfare as well. We are talking about access. Access needs to be guaranteed, and so on and so forth. Okay, another set of words. Here we are referring to the actors within this space and the spaces themselves. So who are the actors here? We have patients, we have doctors. Originally, a doctor means somebody who instructs. Okay, somebody who teaches. Okay, somebody who enlightens. We have a care seeker. We have evidence-based care. And we'll be contrasting that with what has now been referred to as eminence-based care. In other words, a physician has spent 7 years in medical school, I should know. I can decide for you what I think is good for you. But here we're saying, oh no, wait a minute. Where is the evidence that this treatment, this course of therapy actually works? There's altruism. In other words, we are sincere. If you are providing healthcare, you are providing healthcare because you have taken the Hippocratic oath. Okay? You're genuinely concerned about the state of your care recipient. You have a conscience. Money is not going to determine, it's not going to cloud your sense of judgment. And then a new term that has just come in is called quaternary prevention, also associated with this context. Quaternary prevention, if you're not familiar with it, has to do, actually builds on primary prevention. Okay? In other words, the initiatives you take, action you take to prevent illness from arising. Secondary prevention, to do something at the early stages, all right, of the illness before it aggravates. Tertiary prevention, how do you minimize the chronic long-term effects of illness? And then quaternary prevention, is a tongue twister, has to do with actions that are taken to prevent the patient from excessive medicalization. Actions that are taken to prevent the patient from excessive medicalization or from extreme medicalization. It also has to do with actions that are taken to prevent or to protect the patient from medical invasion. The pharmaceutical companies are everywhere. They are selling all sorts of things. They are invading our lives. So quaternary prevention refers to that, but also very critically in the context of this discussion, it also refers to measures that are aimed at ensuring that whatever course of therapy, whatever treatment the physician recommends is based by evidence. Okay? It's not based on the whims and caprices of the physician. There's clear evidence. So this is a term again that is used in the context of power as it relates to patient. Okay, but obviously you also have such other terms that are used, voice, the rights being spoken of everywhere. We talk of, in clinical consultations, we talk of shared decision making. After all, you own your body, and if somebody is going to do something about your body, you need to be involved to some extent in that process. Power and so on, of course, you need to elicit the consent. Okay, so this is, we will claim that this represents one discourse paradigm as far as patient power is concerned, as far as the power of the care recipient is concerned. And this paradigm is made up of the concepts associated with words such as this. So you see the Prash's approach into entering the field where Professor Naya has done so much work. So I just look at the words and get a sense of what he is doing. Whether I'm correct or not is a different matter. That will tell me at the end. Okay. Okay, so let's look at. Sorry, my animation wasn't good. So we have the nurse. So we're not talking of care providers. We are calling people by the names of their professions. There's a lot of bonding taking place here, and so on and so forth. Okay. We have another paradigm, another discourse paradigm, lots of words. I couldn't find enough space to put as many words as I would have loved to. Here, it is the consumer who is at the center. So we're no longer dealing with a patient, we are dealing with what is called a consumer. It changes the dynamics completely. And you see the kinds of words that are associated with this paradigm. Virtually everybody who has spoken has talked about neoliberalism, okay? So won't flog that. They've talked about health reforms, in many cases, inspired by our Bretton Woods institutions. I had to step out a while ago, but I noticed here, you even talked about health as commodity. Health has become commoditized. It's a product, it's like a package of soap, which you can buy off the shelf. Some funny combinations have come up. Health economics, health tourism. Again, I noticed somewhere here that you talked about health tourism. Combinations of words that were perhaps unimaginable some 30, 40 years ago have now surfaced. Of course, free markets. We have to privatize. It's good for competition. And like Professor Kader mentioned, when she was talking about the hijacking of the UHC, and this also came through in Professor Razum's presentation, from talking about making healthcare accessible, providing healthcare to the citizenry, we are now saying, well, as a government, we will provide it, but whether you can access it is a different matter. Our responsibility as a state is now seen more in terms of our ability to make sure it is available. But whether it is affordable, accessible, that's a different matter. We don't want to be concerned about that. The idea being that if government gets off such public sectors, it encourages the private sector to take over. And when the private sector takes over, what do you have? Health becomes commoditized. And health begins to be seen as a sector that needs to contribute to the growth of the economy. Health cannot just be seen as a service which the state renders, it must be seen as contributing to the growth of the economy. I hope Andy doesn't mind, but in many hospital environments, in many environments now, we're speaking of management, managers, administrators. We are still using hospitals, but I'm sure very soon, and maybe in some cases, we don't even speak of hospitals anymore. We are speaking of healthcare organizations rather than hospitals. It's all included. I understand even in this country, hospitals, so-called hospitals, are actually owned by businesses who incidentally get subsidized by the state. Cost control is an issue. Disease mongering. I'm sure you've heard of all types of mongering, but something I also find in some of the literature is disease mongering. And what is disease mongering? It has to do with presenting, selling diseases in such a way as to broaden the group of people who feel susceptible in order to foster sales. Okay? You might even say the WHO definition of health might be an example of disease mongering. Does somebody recall the definition of health? Okay, something along those lines. Is there anybody here who satisfies that condition? I mean, I certainly don't. I don't know about you. So, a strict application of that WHO definition might suggest that we are not healthy. Okay? So anyway, disease mongering has to do with something along those lines, and it promotes health myths. For instance, there's a cure, there's a medicine for everything, for every illness. The earlier you detect, the better the chances of cure, and so on and so forth. Okay, so these then I would like to suggest are some of the words that express concepts related to another discourse paradigm, and we might call this the consumer paradigm in health, the health consumer paradigm. And the first one would refer to, if you like, patient paradigm or the citizen paradigm. Citizen because he or she expects certain services from the state as enshrined in the directive principles of state policy. Okay. Now, both of these paradigms, incidentally, use a number of common terms. Even the term costs or cost explosion is used by both paradigms, but as we will see, in completely different senses. And that is why it is important, when you hear a word, it's important to go beyond the appearance of the word to actually see what the ideology, the worldview that is associated with that word. So I have tried to represent these two discourse paradigms within these intersecting circles, and to suggest that concepts such as power, rights, participation, cost, and so on may be spoken of in these two discourse environments, but as McGregor shows, the meanings may be different. McGregor says that advocates of neoliberalism from the right have gained competence in borrowing words from the left in order to make their points. I mean, I think this could have also been a way of summarizing the point Professor Kadir made on the first day with respect to UHC. She also says that, look, we need to respect citizenship rights as well as consumer rights. All right? There's no arguing the fact that, look, they have to be consumers, but they also have to be citizens. And that we should not confuse both. Now, I have used Arnheim's ladder here. This is quite dated, this is 69, to suggest what the focus, what the interest of these two groups might be as far as power is concerned. Now, like Arnheim himself, I want to admit that this may not necessarily be applicable in all aspects as far as, to health. But Anna basically suggests that there are levels of participation. In other words, there are levels of power or non-power. It's really on a continuum. And what this ladder does is to try and make what is actually a continuum discrete. So there is, at the lowest level, manipulation. All right? Here, you simply tell a lie. This is a lie. This is deceit. Then therapy, you are not addressing the cause. You are simply addressing the symptoms. And by the way, I have developed this in the context of urban renewal, urban development. So there is a level to which it can be transferred to the health setting. There's informing, which is basically a one-way street. Yes, I've been told, but I do not have the opportunity to respond. Consultation. Yes, my view may be taken into account. Sorry, my view may be elicited, but nothing happens with it. I mean, imagine a consultation with your doctor or with your nurse, and he or she asks you a question, and you answer, and there's no sort of, or you ask a question, there's no acknowledgement, all right, of you or of your question. Then placation has to do with, well, some concessions, some real concessions, but restricted, and so on. I'm not really interested in the details of Mannheim's ladder. What I'm more interested in is in suggesting to you the scope that exists when we talk about power of the citizen or power of any kind. It can move from non-power to total power. So I'm more interested in the extremes of this ladder. And I suspect, and this is our claim, that advocacy groups interested in patient power are looking at the higher rungs of this ladder. So when they use power, to whatever extent this is applicable to healthcare, they are looking at the upper rungs of the ladder. However, when pharmaceutical companies and big actors in the neoliberal healthcare environment are talking about power, they are interested in keeping the care recipient at these lower levels. Because keeping the care recipient at these lower levels means that the patient is really not in a position to exercise real power as far as health services is concerned, and they are more vulnerable to being marketed to, being sold medicines and technologies and what have you to. So essentially, advocacy groups, I incidentally noticed that advocacy, well, that was the theme of Marian's thing. Advocacy groups are targeting these higher levels. They are working within the health citizen paradigm, but actors in the neoliberal health environment are targeting the lower rungs of this ladder. Okay? Okay. So then, what do I want to do in this brief analysis? I'll be analyzing some material. Against this backdrop, our objectives here would be to illustrate to you how both the consumer and citizen paradigms in health interact in a piece of text, okay, at an interactional level, okay, in text. I mean, our colleagues, yes, we'll look at this from, policy and, macro perspectives, but those of us who are gate crashers, seeking some relevance where we don't have any, will say, well, let's just look at texts or interactions in healthcare settings to see how these two paradigms are reflected. How do they interact? What is happening? A second objective would be to actually suggest that the consumer paradigm is undermining the patient or the citizen paradigm. And then consistently with the theme of the summer school, we will try to relate this somehow to the whole issue of health inequality. All right, are we okay thus far? Are we fine?
Yes.
Okay, thank you. Okay, so what is the material that we want to analyze? We want to analyze a 10-page letter. I promise I will not analyze all 10 pages. I don't want to keep us here till tomorrow. This letter is routine communication given to women to whom a positive pregnancy test result has been issued. Okay? So you're in a gynecology clinic, you see your gynecologist, and he or she decides to do the test, and the good news has come. Bingo! Amongst other things, cream for stretch marks and all other small things, you are given this letter. And incidentally, this letter was obtained in Bielefeld. Okay? But of course, I'll try and conceal. This is probably a standard letter, but I'll try to conceal the specific gynecologist from whom this was obtained. Now, to situate this letter within the context of health policy, health reform in Germany, one might say this. First, make one admission that related to many other countries, OECD countries, the level of user fees in Germany is not as high as in many other countries, all right, many other OECD things. So there's still a very strong social welfare environment in Germany. However, the marketization thing we've been talking about in healthcare as a result of health reforms, because of the use of the eminent-based care thing, insurance, all right, was concerned that physicians were prescribing therapies that could hardly be justified. There was no evidence. There was a feeling that perhaps somehow sellers, marketers of medical products were having too much of a sway on the professional practices of physicians. So what happened? The well, there's a committee involving federal physicians, other stakeholders, insurance companies, came together and tried to sort of specify the kinds of therapies which physicians should be recommending to their patients for given conditions. In other words, suggest that, look, there's got to be an empirical basis, there needs to be an evidence basis for whatever treatments you recommend, to put a stop to adventurism in prescription, to put a stop also to the exploding costs. Okay, so health insurance in Germany was coming from the standpoint that the costs of healthcare, no thanks to eminence-based practices, was exploding. So we are going to see how this plays out in the text as we go on. Of course, as you can see, the original letter was in German, but it's been translated in a way that doesn't bias the analysis we intend to do. Okay, what's the framework? Very quickly, The framework we'll be using is critical discourse analysis, and on this slide you see just a few points related to critical discourse analysis. It's a research approach that draws from any number of disciplines, and it studies the way in which power, dominance, inequality, and so on are created, sustained, reproduced, but also how they should be resisted. Okay? So how is power engendered? How is power created? How is it enacted? Okay? How is it reproduced over time, intergenerationally, from situation, from context to context? Okay? But how do we also resist it? Again, the bias here is towards texts, all right? Towards analyzing power as reflected in text. What's the assumption of critical discourse analysis, which we abbreviate as CDA? It makes a number of assumptions, two or so of which we present here. The way you use language, the way language is used, especially by experts, especially by people who have power, does not simply reflect what exists. It, in fact, creates facts on the ground. So in other words, the way you use language can actually create reality. So language is not just a passive reflection of what is happening, it can in fact create facts on the ground. I need not remind you of the example I think I gave on my first talk. You go to a hospital with an illness, you know, a feeling of unwell, you come out with a disease. All right? And that label that has been placed on you sets in motion a number of processes in your life. Or in psychiatric care, I mean, the moment a label has been put on you, it changes the entire course of your life. From one minute to the other, you are a changed person. A new you has been created. Or, I need not remind you of the George Bush White House rhetoric with respect to weapons of mass destruction in this or that country. And when everybody got mobilized, got in there, they didn't find anything. Rhetoric, discourse was used to create weapons of mass destruction, which did not exist. Okay, so language used by powerful people does not simply reflect what exists, it has the potential of creating reality. Today, the second assumption, today, power is exercised not so much through coercion, through brute force. It is more through the manufacture of concepts. It operates in more subtle ways. Power today is more of ideology than somebody pointing a gun at your face. I'm not saying that that does not exist, but some would even claim that that is not even as effective as the more subtle exercise of power. And in this exercise of power, of course, language plays a very important role. Third assumption, to avoid being challenged, to avoid being criticized, to avoid being detected, the ideological uses of language, when powerful people use power to subvert other people's interests, what do? They don't make their agendas, very explicit. It is concealed, it is hidden, okay? So essentially you need the right set of lenses to see that power, because people make them look natural. And my task, hopefully in this talk, is to give you these lenses, okay? To be able to recognize power as enacted in text, so that if you want to be a good student of Marins, you want to get involved in advocacy, you can say, hey, don't be carried away, don't be fooled. This is what is happening here. We must resist this. Okay? Whether I will be successful, we'll see. So the mission of critical discourse analysis is essentially to expose and encourage resistance to exploitation, domination, and so on and so forth. I'll just skip through this. Some findings related to strategies which powerful auspices use in text or in while speaking have been listed on this slide. But I think the overarching thing is that discourse has been technologized, by which Fight Club means that in a neoliberal environment where there is so much concern for profit, people who provide services have researched forms of communication that support profit making. I mean, I'm sure our experience in many countries is that when you want to buy a product, when you want to buy a car, the salesperson is so sweet, so nice, so everything. But the moment you buy that item, it no longer exists. 12 hours after it develops a problem, the treatment you get is very, very different. Or you go to complain, before you even start, oh, I understand. Oh, that must have been very awful. We're so sorry. So they are researching language to see what forms of language can be used in order to promote their economic interests. Something I just realized here when I arrived is that, unknown to me, I was actually burning up the airtime of a colleague. Because these messages come, unsolicited messages, who is the actress, the leading actress in the so movie. And in the process of trying to maybe press cancel, you press OK, and 7 rupees gone. I mean, these are all technologies of communication in order to what? To make money. Okay, so how does this manifest in concrete terms? Democratization of discourse. In other words, removal of overt markers of power differences. I mean, typically, we would say doctor's orders to illustrate the fact that a doctor is the all-knowledgeable fellow, and you, the poor patient, know nothing. So the doctor instructs you, do this, no questions asked. But in today's neoliberal environment, as we'll see in this text, that hardly exists anymore. We make it appear as if we are jointly exploring your healthcare needs. It's participatory, you know. In education, we no longer talk about the teacher-centered, okay? The teacher is more of a facilitator. He or she is guiding the learners along, not standing in front, but constructive learning, that's another term it's used, you know. So everywhere we see an attempt to remove overt markers of power. We also see, when it is suitable, an attempt to simplify things, to remove technical clutter, all right? To remove technical vocabulary. We see increasingly the adoption of a conversational style, all right? We see synthetic personalization, by which is meant treating, okay, let's put it this way. I am addressing a mass audience, but I treat each one in that mass audience as though they were unique. Okay? You enter your Yahoo or your Gmail, it says, welcome, Naya. It makes you feel, they even know my name. Okay? This is great. You get some of those masters telling you, you have done so well and want to put you in the book of some encyclopedia of very successful people. they call you by name, and you feel good. But then later, they ask you, please send us your CV. But if I were this successful, you should have known all of that. So they make you feel as though you were unique, but it's all mass sent out. Okay? Technology, of course, assists here. So that's what is referred to as synthetic personalization. I'll quickly run through. Legitimation simply says, look, I know what is good for you. I'm going to protect your interests. Okay? I know what is good for you. Role allocation, you are not made to feel passive. You are given agency, you are given a voice. You are given the impression that you are actually participating, you are calling the shots. But the truth is that somebody elsewhere, you're a puppet. And very often we fall for that. Interdiscursivity, we are drawing on conventions from different kinds of texts. In an advisory from a healthcare professional, I will not expect to see marketing information. I will not expect to see a contract type information. But increasingly, what we're saying in communication across fields is that to be effective, okay, in today's neoliberal environment, you've got to draw from conventions of different text types. So there's a lot of blending. Today we speak of infomercials, infotainment, and so on and so forth. We're blending. There's a lot of hybridity in text types. And it's not an innocent thing. Okay? I'm sure, have you heard of edutainment, infotainment? So it's a blend of information and entertainment, infomercials. It's a blend of information and commercials. In many countries, if you watch TV late night from about 12 a.m., the way they market certain items, especially in the US, if you call in the next 3 minutes, this is what's going to happen. Actually, if you call within the next 1 minute, we will reduce the price by half. And not just that, we'll give you 3 pieces of this. Please call, operators are standing by. But before it gets to this point, they would have spent some 15 minutes making you feel that you could not leave tomorrow if you didn't buy these products. Okay? Lots of information. It's not innocent. It's aimed at making you buy. Okay, manipulation, and so on and so forth. Let me skip this. Let's now go into the analysis proper. We would like to suggest that in this letter we are going to analyze subversion of the patient's rights, of the patient's power, takes the following form. The gynecologist identifies with the patient, makes her feel, oh, look, you're a family member. I will do absolutely nothing to hurt you. Okay? Then, once trust has been earned, that capital of trust, how does the gynecologist expend it? In attacking provisions of the welfare state, in showing problems with certain policy provisions, and then our colleague this morning said that one of the fastest growing industries today is creating fear. Fear creation is a growing industry, instilling a lot of fear in you to make you even more vulnerable. So then comes the adverts. Why this is good for you. And then we'll see a consent form which we'll discuss in terms of interdiscursivity. Okay, so let's start with a quick analysis of the letter. I'll just take a few pages, and as much as possible, we'll try and see how interactive this can be. So this is the letter that has been issued. By the way, the name there is not the original name, but in Germany, every 6th person is a Maya, and every 7th person is a Claudia, so there's no problem there, okay? Congratulations, you are pregnant. In what follows, we have put together for you tips and advice on pregnancy. What constitutes a healthy diet in pregnancy varies from person to person. Okay? So it goes on to tell you the kinds of things to eat, what to avoid. However, nicotine, alcohol, uncooked meat, and unprocessed milk are don't go those. It is advisable to cut down on coffee, black tea. Even recommends a specific type of tea. The required amount of calories varies and depends essentially blah 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 blah. If you are the relaxation type with a tendency for increased body mass index, you should take drinks that are low in calories, etc. In addition to, okay, it goes on and on. A couple of questions we might ask. We are accustomed to doctors giving orders. Prescription. You watch Dr. Oz. At the end of his program, he says, doctor's orders. Doctors have been traditionally socialized into giving orders because they are knowledgeable. And what do you know? You've not spent 7 years in medical school. So already we see that the choice of text type, rather than give this as a set of instructions, do this, do this, do this, it's a letter. This letter does not say, dear Clarence, dear pregnant woman, or dear all, whenever we write our mass emails. Dear Mrs. It actually names the person. Okay? If you look at all the things that are mentioned here, and you ask yourself, in whose sphere of influence does it lie to implement these things? Who has responsibility? Who has the agency to implement the things here? Yes. It's Mrs. Meyer. The gynecologist has taken a backseat. Mrs. Meyer, it's about you. You are the powerful one. And these are not medical things. These are not medicines or technologies. These are things in Mrs. Meyer's familiar environment upon which Mrs. Meyer can act. So Mrs. Meyer is a powerful person here. If you look at the readability, apart from a few words which perhaps the average educated person may not know, maybe body mass index and unsaturated fatty acids, the text is generally very readable. But you see that this will change later. The effects we claim, which this format has, and of course, if you listen to Oliver, he talks about causal thinking and epidemiology. Please suspend that act. We are not doing the sort of causality which you will do in epidemiology. We are suggesting here, okay? The effect we claim that this has on Mrs. Meyer is to make Mrs. Meyer feel that this gynecologist is attending to me almost in a very personal way. I'm being addressed directly. Congratulations, you are pregnant. The gynecologist introduces himself or herself into, we have put together, I and my colleagues, the medical establishment, we have put this together just for you, Mrs. Meyer. Of course, it is very special. But we'll see whether what we claim to be the perception of power that Mrs. Meyer has when this letter begins is sustained throughout the letter. So, bonding is taking place here. Then the letter goes on. And I would like you, as you read this letter, let's spot the neoliberal attack as the letter progresses. That most pregnancies, the fact that most pregnancies in Germany end with the birth of a healthy baby is something we owe to the existence of a standardized screening program, which is governed by the so-called Maternity Act and guidelines of the Federal Committee of Physicians and Health Insurance. When you say so-called, what do you mean? So Benanto. Yes. When you say so-called, what's the attitude? Question mark. Question mark. You are discrediting so-called maternity act. It does not deserve to be called maternity act. So-called. Okay? The mandatory screening prescribed in the Maternity Act, that is, gynecological exams, lab tests, ultrasound, provide an adequate level of safety and are covered by health insurance. However, by law, health insurance is allowed to provide coverage only for services that are adequate, effective, economical, and do not exceed what is really necessary. But there's much more that medicine can offer. This information sheet tells you several clues of what you consider a neoliberal attack on the existing welfare provisions in Germany. Let's look at one argument. This letter is saying that insurance would have offered more coverage for unrestricted services but for the law. Insurance offers effective services, therefore, effective services are restricted. That's the thinking. That's how you can process it logically. So, the last time I checked the dictionary, there may be some argument as to whether adequate means excellence, or it means, for instance, in the grading script in Germany, for instance, when you say ausreichend, adequate, like fair, there can be, and these are some of the problems in the translation. I'm not quite sure which is which, but can there be any doubt that something that is effective is positive? I don't believe so. If you say this is effective, it means it's delivering the results. But see the way this letter questions what is effective. And then it says, however, by law, health insurance is allowed to provide coverage only for services that are adequate, effective, economical, and do not exceed what is really necessary. What's the problem with that? Why would I want services that exceed what is really necessary? Why would I? You want to say something?
Maybe more status.
For status? Exactly. And that's where you become a consumer. That's when you become a consumer. So, you begin to wonder, what is happening here? Then let's look at what seems like a very neutral term, standardized screening. Standardized is almost presented as a one-cap-fits-all thing. All right? So, irrespective of, somebody used the term not interconnectivity, it's in the first lecture. Well, I think the talk was about the role which gender, religion, and intersectionalities. Thank you. Yes, intersectionalities. So a one-cap-fits-all, the standardized thing, does not take into account those intersectionalities. So, if all pregnancies carry some risk, what is the problem with standardized screening? Which in any case leads to the fact that most pregnancies in Germany end with the birth of a child. So you can see in very subtle ways how this letter is preparing Mrs. Meyer to buy more services. It is gradually preparing the ground for Mrs. Meyer not to limit herself to services provided by insurance, but to go beyond that. Consumption is good for the economy, all right? Even if it is not really, really necessary, but please buy more, buy more, buy more. Which dovetails into one of the myths of health, that the more the better. It may not necessarily be so. Okay, so we continue. The answer is that who needs it? Well, the economy needs it. It makes health a growth industry. So what's the solution? Well, buy more health products, more health technologies, buy into all of that. So you see how this ties in nicely, I would claim, with that other paradigm where we talked about excessive medicalization, which contrasted to what we refer to as quaternary prevention, okay, in which the physician tries to protect the patient from the invasion of medicine, tries to protect the patient from over-medicalization. Font size may look like a small issue, but highlighting that there's much more that medicine can offer forces you to attend to that part of the message. It brings it out and forces you to focus on this. And remember, we're talking about a pregnant woman. For most women and their families, this is about one period in their life where they are perhaps most amenable to exploitation, to manipulation. Who doesn't want to have a healthy child at the end of that process? So anything you can do, you will do to ensure that. Okay, just a final thought on this part of the letter. Legitimation. You see the gynecologists, even while attacking the social welfare system, is still trying to show solidarity with Mrs. Meyer. I know what is good for you. That's why I'm saying there's so much more that medicine can do. Please don't allow these bureaucrats, don't allow the insurance industry to limit you. Your baby needs much more than they're offering you. Please, we have put together this information especially for you, Mrs. Meyer. Okay? And of course, in fairness to the letter, it says may improve. It does say will certainly improve. But by the time you have been so thoroughly put under emotional, psychological duress, you probably wouldn't notice that it said may and not will definitely improve services. Okay, so now we begin some adverts. What is the additional service that the gynecologist is trying to sell? It's called local translucency and combined anti-measurement. But before selling this, as you're going to see, the gynecologist tries to do what? Tries to create a lot of fear and to discredit amniocentesis. He says, every expectant mother has in principle a very high probability that her unborn child will be healthy. And healthy here is defined as free from physical disability associated with a reduction in quality of life and free from diseases associated with altered shape or number of chromosomes. I did not know that that was the definition of healthy. This is obviously a self-serving definition. Altered chromosomes is fronted because that is what I want to focus on. The most common, the most well-known, the most significant, okay, superlatives. The most common means you could be susceptible. Your unborn baby could be vulnerable. Disease mongering. The most common, the most well-known, the most significant chromosomal disorder is Down syndrome, which was formerly called Mongolism. It goes into statistics which are correct here, but as we all know, you could use correct statistics in a way that manipulates. Fortunately, I've been having a running discussion on other matters of this nature with our statisticians. It has long been known that with the increasing maternal age, there is an increase in the probability of a chromosomal disorder. This is why pregnant women who are 35 years and above are offered amniocentesis by health insurance. In other words, health insurance in Germany would offer amniocentesis only to women who are older than 35. But for good reason. The scientific evidence, I am told, clearly supports this position. Before I move over to the next slide, what we notice here in terms of the letter is that it has become more formal now. Okay, all of the you, we is gone. Mrs. Meyer is almost disappearing. There's no personalization. And the text, because of the technical terms, has become much more challenging to read. I think in an informal readability test I did, 1 in every 10 words presented some challenge, whereas in the first part of the letter it was about 1 in every 80 words. So Mrs. Meyer, we would suggest, is gradually moving down that ladder. From being at the driver's seat at the beginning of the letter, she is gradually slipping. I don't know how many people of average education would understand many of the terms that are used here. Okay, now let's focus a little bit on the statistics. With amniocentesis, however, only 30% of children with Down syndrome can be detected. This is because 70% of all pregnant women whose children will be born with Down syndrome are younger than 35 years. Remember, health insurance offers a related service only to women who are older than 35 years. And because women who are under 35 years represent an important segment of the market, all right, it's important to engage in disease mongering. It's important to make them feel just as susceptible, just as vulnerable as women who are over 35 years. So it now says to provide assistance specifically targeted at these younger women and to avoid unnecessary procedures. That is why a number of new tests have been developed. And it goes on to advertise the strengths of these new tests. Now, let's just assume that, I mean, when I hear, as a layperson, when I hear 70%, it's quite frightening, right? 70% makes me feel I'm extremely, extremely vulnerable. But if you assume in a certain population that each year there are 100,000 deaths by women, irrespective of their age. Now, with 1 in 650 babies being born with Down syndrome, there will be 154 such babies. The under 35 mother share of these 154 babies is 70%. 70% is carried, but the raw figure is 107. Now, the point is not to say that that is excusable. I mean, every baby, any individual baby that is born with Down syndrome is a concern not only to the mother, family, and all that. It's nothing anybody cherishes. It's nothing that should be dismissed. But the point we're trying to make is this: when you express this in terms of percentages like this, then you are adding to the sense of vulnerability which the mothers have. So the claim here is that the use of statistics has a way of biasing the information and making people feel even more vulnerable than they may have been if raw figures had used. And by the way, the letter started with Mrs. Meyer. Somebody certainly should know Mrs. Meyer's age and speak to her. That has disappeared. We have now gone back to what we're used to, very generic sort of things, not particularized. Okay? So the focus on Mrs. Meyer at the beginning of the letter was only intended to suck her in, draw her in, and then once that capital of trust has been earned, you now expend it on manipulation. So that's why we ask her, is Mrs. Maya, does she still exist? Is her age unknown? Okay, now it goes on to talk about nuchal translucency itself. It goes into details, very technical for me, but I think the point to be made here, okay, let me just read maybe the first line or so. Nuchal translucency usually occurs almost in every child in this period. It is an average about 1.2 millimeters at the gloss color and neck. If the NT is bigger than normal, this can be a significant sign of possible chromosomal. So it goes on and on. But the claim here is that the information on NT is presented in a rather biased manner. Things are not as clearly explained to the Mrs. Myers as they were explained at the beginning of the letter. For instance, it's not been clearly stated. Yes, you can infer this because you are knowledgeable, but it's not been clearly stated that the science of this is not very exact. Let's look at one example. It's 1.2 millimeters is normal, right? That's what it says. But 2.3 millimeters could indicate a serious chromosomal disorder. The best it can do is to suggest that there may be something there. And the reaction of the mother and the families could be one of three things. Oh, nonsense, I'll ignore it. Or, maybe we should abort the baby. Or, further tests, in this case amniocentesis, will be required. Now, if families, for whatever reasons, abort the baby on account of a test result that says there just might be something, and I'm informed that on many occasions there's actually nothing, what has happened? Couldn't this letter have been much more explicit in letting Mrs. Meyer know that the follow-up amniocentesis is not without risks? I'm sure he could have done that.
Yeah, much to be.
But it is not in the interest of the individual who wants to sell NT measurement to do that. That's the point we're making. So, what I'm trying to do here is to suggest that even in a fairly technical, science-oriented thing, you could still have evidence of practices we probably should regard as manipulative. All right? Okay, so the letter now ends with this. Consent forms, since litigation became a very strong presence in healthcare, become part and parcel of care delivery. So there's no doubting that. But when you have a text such as this, coming against the backdrop of psychological manipulation, drawing from sales, almost looking like a contract, you begin to wonder what is happening here. Declaration. I, Mrs. Meyer, Claudia, born. Okay, I used the 30th of March 2012 because Mrs. Meyer was not born today. But so obviously somebody knows her age. Yes, somebody knows her age. It's in the records of the practice. I declare that I have received sufficient information. I wish to obtain the following services. Listed about 14 or so, no, 12 plus 3. 15 services are listed, each with a price tag. Okay? These services, don't worry, Mrs. Meyer, if you don't have cash, I mean, you can pay by cash, you know, at the practice of the surgery. But if you don't have cash, it's not a problem. Bring out that debit card, you can still use it.
Is this something you would have expected? No.
in communication with the mother who is pregnant, so you're advising, this discourse does not belong here. But if it has been brought here, it is because there is an objective we are pursuing. I am aware that according to the fee schedule I personally have to pay for the services. They are not listed as services provided by. I'm also aware that I cannot ask for any refund, okay, because I have received a copy of this declaration. So what is the psychological effect this has on a vulnerable Mrs. Meyer, who has now been presented with a situation the chances of my unborn baby being born with Down syndrome are high. Matters are not helped when the doctor, by this document, is almost saying, it's clear that I have told you. In the event of anything going wrong, please don't hold me responsible. You have been educated, you have been informed, you have been thoroughly educated. So in a sense, this page exercises a lot of pressure, further pressure on Mrs. Meyer. Because what it does is to exculpate the physician of responsibility in the event of something going wrong. So Mrs. Meyer, if she has any power left at all, it is the power to succumb to this. Even though the benefits procured, the jury is still out with respect to the benefits procured by this procedure. I have received a copy of this declaration. So it's not just signing, I have received a copy of this declaration. Now, something that might seem innocuous, but for a critical discourse analyst is not, is the fact that, you see these two lines here. I'm sure formatting was not a challenge. You could easily have included what they should be. Should it be dates, place, and this signature? That information, we claim, is placed strategically on the following page of the original document, where we have a pregnancy chart. And our claim here is that what this does is to quickly remind Mrs. Meyer that this is about you. It's not about money making. All right? This is the sort of thing you probably would want to expect. Okay, so what has happened here is that Mrs. Meyer now, with respect to this particular procedure we'll be looking at, now has to decide whether or not she should part with the 110 euros. Okay? Okay, let's look at, this is my last slide. Let's look at what implications this may have. Can a Mrs. Meyer in Bielefeld or a Mrs. Dasgupta, okay, in Uttar Pradesh, in some locality in Uttar Pradesh, and their respective families resist paying for these additional services, in other words, making out-of-pocket expenses for health services that procure questionable benefits? Can she really resist? How does either woman's power as caretaker actually play out? Is it as right to having truthful information, truthful education from a doctor, the meaning of whose profession is to instruct, to teach, or is it the right to spend, not out of their free will, not out of their free volition, but under a lot of psychological pressure. McGregor says that the neoliberal logic accepts purchases in the private market as evidence of citizen participation. In other words, your citizenship is defined in terms of your pockets, your ability to pay, because that is what grows the economy. That's what makes the state exist. Because the citizen is reduced to being a consumer, people are free to decide whether they're going to spend their money on healthcare or some other category in their budget. And McGregor says this is a convoluted perception. It's a wrong, it's an immoral perception of right to choice versus a right to voice. Okay, just to tie in finally, how do we tie up this one with health inequality? In my first presentation, I did allude to one of Mackendach's pathways for reducing inequality related to health, and that had to do with money, with financing, with economics. Now, of course, with this example, we cannot talk of catastrophic expenditure, but in examples where we could, where the entire household income, okay, goes into attending to a sick member of the family, then health can become a reason why people drop. Okay? And I think on that note, I will stop here, and I hope I'll be able to give you a little sense of just how these two paradigms interact, and how one just might be subverting the other. And that even though they use the same sort of terms, power, right, costs, completely different views of the world, completely different ideologies. Thank you.